site infections. I am not a neurosurgeon. I have not done neurosurgery since the first year of my residency in 1970. But the issues related to surgical site infections are shared throughout different surgical specialties. I have no conflicts of interest on this lecture. Here is a list of many of the topics that can be addressed regarding surgical site infections. I will focus on prophylactic antibiotics. I will avoid talking about colectomies, since I don't think you do those. And I will talk about many of the other issues listed here, and happy to take questions at the end. Starting with prophylactic antibiotics, which, by the way, was first introduced during the first year of my surgical training. I like to ask these 5 questions. We will begin with which cases benefit from prophylactic antibiotics. On this slide, we see the comparison of results from many controlled trials over the many years, comparing antibiotic prophylaxis against placebo and for different types of operations. And where the placebo rate of infection is high, we have the biggest change. And we see here under number needed to treat, the number of patients that need to get prophylactic antibiotics to prevent 1 infection. For colectomies, it's only 3 to 5. For something like vascular operations, where the rate of infection is lower, you need to treat more people to prevent an infection. And here we see for craniotomy and spinal operations, there's a significant reduction and a moderately increased number of patients to treat to prevent 1 infection. Now, these data from this slide are very old because almost no one does placebo trials in prophylaxis anymore, because we understand so well how the benefit is. And Bowater, a number of years ago, looked at many different trials and found the relative reduction in infection rates is pretty much consistent. It's around 30 to 50% of infections can be prevented. But if you have higher rate of infection, then you are preventing more infections. Bowater created this graph. As we move across the graph from the left to the right, we see increasing baseline risk of infection. But what we see is that the relative risk, the relative reduction in infections, is similar throughout all of those different areas. So the relative reduction is the same, but the absolute reduction in infections is less if the baseline placebo rate is less. So the decision on whether to use prophylaxis depends on the cost. How many dollars do you have to spend for antibiotics, the side effects of antibiotics, the risk of generating resistance when too much antibiotics are used, and the cost of infection, dollars, disability, etc. I think for most neurosurgical procedures, the cost of infection is quite serious to the patient, and probably the overwhelming majority should benefit from prophylactic antibiotic use. Which drug should you use? This is my standard slide, and you see, since I, as a general surgeon, did lots of intestinal operations, here's what you use for bacteroides. But most people don't have bacteroides in their brain or their spine. So basically, cefazolin, or the primary cephalosporin available in your setting, is usually the standard antibiotic for prophylaxis for those types of procedures. Here's an interesting study that came, I think it came from Spain, in a hospital where they were using cefazolin for cranioplasty operations, and they had an unacceptably high infection rate of 22%. And so they found that they were having their infections caused by bacteria resistant to cefazolin. So they started a new protocol. And what they did is they did skin and nasal cultures of their patients before operation to find out what the standard bacteria on those patients were. And then they chose a prophylactic agent effective against what they were finding on the patient. And they got their infection rate down to 4%. So this gets to the point that prophylaxis, to be effective, does need to be effective against the bacteria that most commonly cause infections and most commonly are found on patients where you are operating, and this may be different in different places. Another issue about prophylaxis is the question of penicillin allergies or other allergies. And what I learned was when a patient would tell me they were allergic to penicillin, I would say, what reaction do you have? And the patient might say, I get a rash, or I don't know, I was told I was allergic as a child, or I get nauseated or itch or yeast infections. And most of those things are not serious, may not really be allergies at all, certainly not yeast infections. And it means the patient could get penicillin if indicated, or could get a cephalosporin. The other issue is that most people who even have true penicillin allergies are able to take cephalosporins. So up to 10% of the population, at least in my country, will report being allergic to penicillin, when in fact 85 to 90% of them are not allergic and are able to tolerate penicillin or cephalosporin. But this can lead to unnecessary use of costly antibiotics or less effective antibiotics for prophylaxis. In this study by Wilhelm et al., just this year, they had 17% of their patients reporting allergies, and those who reported allergies had a higher rate of infection, primarily because they were getting the wrong antibiotic, even when that was not necessary. Okay, so we've decided we're going to give prophylaxis, and we know what drug we want to use. When should we start? The earliest studies in prophylaxis were done by a hero of mine, John Burke, who was a surgeon at Mass General Hospital almost a century ago. And he did this experiment in rats where he gave penicillin at the same time as contaminating a wound, or 1 hour later, 2, 3, or 4 hours later. And what you see is by 3 hours, giving penicillin didn't do any benefit to the rat in reducing infection size. So this gave us the idea that antibiotics to prevent a surgical infection must occur at the time of incision or before incision. And when I was starting my training, we used to give an intramuscular dose of antibiotic to the patient while they were still in their bed in the hospital, and then transfer them to the operating room. And sometimes it would be hours between the time the antibiotic was given and the operation started. And Dr. DePiro, who is a famous pharmacist, compared antibiotic levels in the blood or the serum of patients if they got their antibiotic on call to the operating room, or if they got it from the anesthesia doctor after the patient got to the operating room and got the anesthetic. And what you can see is at the time of incision and 1 hour and 2 hours after incision, much higher levels of antibiotic in the blood if the patient got the antibiotic in the operating room intravenously right before incision. And looking at muscle levels, same thing. At the time of incision or at the time of wound closure, higher levels of antibiotic when the patient got intravenous antibiotic from the anesthesia doctor, and many fewer patients who had no drug detectable at the end of the operation. And we know that the best results from prophylaxis come if there is antibiotic in the serum and in the tissues during the entire time the wound is open. And this looked at the timing, and what DePiro showed in his study was the average time between giving the drug and incision was 17 minutes with high muscle levels the whole time. Now, there had been a number of studies examining large numbers of patients receiving antibiotics. And in this study, looking at vascular operations in the Netherlands, we see they compared getting the antibiotic more than an hour and a half beforehand, or 60 to 90 minutes before, or 30 to 60, or 1 to 30 minutes, or after the incision. And you can see that the lowest infection rate happened when the antibiotic was given during the 30 minutes before incision. In another study that I helped with, looking at patients having cardiac arthroplasty or hysterectomy, again, the lowest infection rate occurred when the antibiotic was given during the 30 minutes before incision. Koch looked at the exact timing in over 4,000 patients and looked at the incidence of infection and did a fancy mathematical curve to look at the risk of infection depending on the time of administration. And mathematically, the lowest risk occurred when the antibiotic was given 4 minutes before incision. Now, something that precise is not necessary, but certainly within 30 minutes before is beneficial, and up to 4 minutes before the incision is fine. Then there's the issue of, if the operation goes for a long period of time, do you need to give another dose of antibiotic? And in this meta-analysis, you can see that giving another dose of antibiotic when the operation is long caused a significant reduction, almost 50% reduction in infection risk compared to giving only one dose for long operations. So the evidence suggests that having good levels of antibiotic in tissue and blood during the entire operation reduces infection risk. Dosing close to the incision, redosing for long operations, using increased doses for patients who are heavy is a logical way to accomplish this. How much should you give? Well, what we know is that more drug is better. This study done many years ago at the Mass General Hospital looked at patients who had no antibiotic detectable in their serum at the end of the operation. And of those 11 patients, 3 got infected. For patients who did have antibiotic detectable at the end of the operation, only 2 out of 175 got infected. So having detectable antibiotic for the entire duration of the operation is important. This study was done by Richard Platt at Brigham and Women's Hospital, again in cardiac patients. And what they did is, when the patient went on pump, they took a small piece of the atrial appendage and tested the level of drug in the tissue of the atrial wall. And what they looked at is the average drug level in patients who got an infection was 6. The average drug level in patients who did not get an infection was 13. In other words, infected patients had less than half as much antibiotic present in tissue. So more drug for the entire distance of the operation is what is the best protocol. Always give a full therapeutic dose, give larger doses, and repeat doses. This paper is a guideline recommending antibiotic prophylaxis, which was a combined effort of the American Society for Healthcare Pharmacy, the Infectious Disease Society of America, the Society for Healthcare Epidemiology of America, and the Surgical Infection Society. And in this paper, we recommend for most cases cefazolin 2 grams if your patient is over 80 kilograms, 3 grams if your patient is over 120 kilograms. Okay, how long should antibiotics be continued? All the early studies of prophylaxis compared 3 doses over 12 hours compared to placebo. But then they started doing studies with a single dose, all of which showed good effect. And whenever compared, the shorter course has been just as effective as the longer course of prophylactic antibiotics. One of my favorite studies is this one from, it's either Norway or Sweden, I forget. They were looking at hip replacement operations, and they compared 12 hours versus 2 weeks of antibiotics, and you can see there was no difference in infection rates. McDonald did this study where he compared a single dose against multiple doses of prophylactic antibiotics and looked at the odds ratios. Those of you who can count fast will see that there are 14 above the line, 14 below the line, and the various ways of combining all 28 studies show no benefit to multiple doses compared to a single dose, as long as you have it for the entire duration of the operation. The most recent infection prevention guidelines from the World Health Organization and from the Centers for Disease Control both conclude that prophylaxis should not be prolonged after completion of the operation. In other words, once the incision has been closed and a dressing put on, you can stop prophylactic antibiotics. And that prevents the risks of too much antibiotics, such as increasing resistance, increasing cost, and increasing the risk for C. difficile. What about oxygen and surgical site infections? This is an interesting study done by Thomas Hunt, a famous surgeon from San Francisco who did a number of studies about infection risks. This again is an animal experiment looking at the severity of a generated wound infection. And you can see that they expose the animals to 45% oxygen, or 21% oxygen, or 12% oxygen. And animals with more oxygen had lower infections. Hopf, who was a colleague of Hunt, then did this next study in humans. They took patients having operations, and when the operation was over, they used infrared technique to measure the level of oxygen in the tissues next to the incision. And they had low oxygen levels and high oxygen levels. 0% on this slide represents the expected infection rate based on a risk factors of each patient. And what you can see is patients with low oxygen in the tissue had higher than expected infection rates, while patients with high oxygen levels in the tissue next to the incision had lower than expected infection rates. This is an observational study looking at patients who had abdominal operations, and again, looking at the tissue levels of oxygen in patients who did not develop infections or did develop infections. And while you can see there's certainly overlap, was a significantly higher rate of oxygen in tissues in patients who did not get an infection. So oxygen tension in the tissue, in the wound, is important, but how do we translate that into clinical practice? One of the issues is temperature. Rabkin, many years ago, did a study when he looked at tissue oxygen tension compared to temperature. And if he increased the subcutaneous temperature by 4 degrees centigrade, that increased the oxygen tension by 40 torr. And there was a linear correlation between temperature and oxygen tension. And there was an increase in local tissue perfusion. And all surgeons know that a well-perfused wound heals better and has lower risk of infection than one that is not well perfused. Melling in England looked at local warming of the area of the incision in some clean operations and found that there was a lower rate of infection, 4% compared to 14% in patients who did not have any warming, and a higher rate of antibiotics used in patients who were not warmed. Now, what happens to your temperature when you have an operation? If we're all sitting around not having an anesthetic and in comfortable conditions, our core temperature is probably close to 37 degrees, but our skin and subcutaneous tissue is significantly lower. That's how our body maintains our core temperature. But then if you have anesthesia and you have vasodilation, your core temperature moves out to the skin and the subcutaneous tissues, and your core temperature drops. And over time, there's a rapid fall initially, and then your body compensates at a lower rate. So if you pre-warm the patient, then you warm the subcutaneous tissues and you reduce the amount of temperature dropping that occurs when an anesthetic is given. Now, if you raise the operating room temperature very high, you're still colder than the patient's core temperature, but then everyone in the room is miserable and the surgeon is liable to sweat and drip on the patient. So pre-warming and active warming the patient in the OR is much more effective than raising the temperature in the operating room. And active body surface warming in this study, in this Cochrane review by Madrid, showed a reduction in surgical site infections, a reduction in shivering, which is one thing patients hate, and no difference in the types of warming systems that were used. Again, what about oxygen? How about the inspired oxygen tension? There's been a lot of controversy over this. There is one study in spinal surgery that was done by Maragakis in 2009 when they compared spinal surgery patients that had infections or did not have infections. And what you can see is that the average inspired oxygen concentration was higher in patients who did not get infections. But this is observation study, of course, not a controlled study. This is a review of many different studies comparing 80% oxygen versus lower percent. And what you see is a strong suggestion of reduced infection risk for higher levels of oxygen. But there's been a lot of controversy, and there are some in the anesthesia community who don't like this. What I believe is that a high inspired oxygen is probably beneficial, but it's not sufficient because you need to control things like temperature and blood volume and that sort of thing. Oxygen is relatively inexpensive, it's safe, it has been recommended by both the World Health Organization and CDC, and many of the trials that did not show a benefit did not control temperature and fluid management, which, as we've already discussed, clearly influences the amount of oxygen that gets to the incision. And it's oxygen in the incision that makes the difference. What about glucose and surgical site infections? Well, we all know that diabetics have a higher risk of infection. And I became very interested in this topic when I reviewed this article by Latham in 2001. He looked at the risk of infection after median sternotomy based on the highest level of blood sugar recorded during or after the operation. And what you can see is for any blood sugar above 200, there was a greatly increased risk of infection. But when I read the article very carefully, I was astonished to find that 48% of diabetics had high blood sugar, 12% of non-diabetics. But since there are many more non-diabetic patients than diabetics, half of all the high blood sugar episodes were in patients who did not have diabetes. And the risk of infection was twice as high for high blood sugar, whether you were diabetic or not diabetic. So then we started looking at many different reports. And what you see here, this is another example of relating blood sugar levels to infection risk. This was done by the group in Portland, Oregon. And what you see is what I call a dose response curve. Higher blood sugars, higher infection rates. And you see this connection in many different types of operations. Here it is for vascular surgery from the Netherlands. Again, higher glucose levels, higher infection rates. Here it is for general surgery. Higher blood sugar levels, higher infection rates. This study was done in the Cleveland Clinic for over 2,000 patients who were not diabetic having a colectomy at the Cleveland Clinic. And what you see is 2/3 of the patients who were not diabetic had a blood sugar above 125 at some time during the operation. And look at this increase in mortality, sepsis, surgical site infection, and reoperation for any blood sugar above 125. This is a study that we did in our own institution and in the state of Washington. We had a system where about 50 hospitals in our state of Washington shared clinical data about patients. And what we see is these are patients with diabetes, higher infection rate with higher, this shows, did the patient get insulin? This graph shows, did the patient get insulin? And what you see is that diabetic patients with higher blood sugars got more insulin. Patients who did not have diabetes had a lower rate of getting insulin because the anesthesia team wasn't worried about non-diabetic patients. And so they didn't measure blood sugars and they didn't give insulin. And what was the result? Here are the increased levels of infections in diabetic patients and in non-diabetic patients for the same levels of blood sugar, what you see is patients without diabetes who had high blood sugars had higher infection rates and more cardiac events and more mortality than patients with diabetes who had the same levels of increased blood sugar. Now, I'm not a fancy endocrinologist. I can't go into all the molecular things that go on in diabetes, but my simple surgical brain says diabetic patients' bodies are more used to high blood sugars, and so they didn't have as much bad results for the same increase in blood sugar as the non-diabetic patients did. This is a study that we just completed in my institution at the University of Washington. We looked at over almost 6,000 patients having general, vascular, or obstetrical operations. 16% were diabetic, 84% were not diabetic. What we found is that 91% of the diabetic patients had at least one blood sugar over 140 during the first 24 hours after the operation. 50% of the non-diabetic patients had an elevated blood sugar. So not as many, but that's a lot of patients. Almost 2,500 patients. And any blood sugar above 180, almost a fourth of the non-diabetics. And how much infections did we see? How many adverse events? Diabetic, non-diabetic, diabetic, non-diabetic. For every increase in blood sugar, there are more surgical complications. And for the same level of blood sugar, more complications in the patients without diabetes than the patients with diabetes. So the risk of high blood sugar is lower in non-diabetic patients, but it is not zero. It is significant under the stress of surgery, and the consequences of a high blood sugar in non-diabetic patients are more severe than the consequences in diabetic patients. A group of us connected to the World Health Organization looked at a meta-analysis of studies comparing different levels of target for control in operated patients. We compared control targets between 110 and 150 to targets 180 to 220. And what you see is that there's a very significant lower rate of infections in patients with the lower rate of blood sugar targeting. In fact, almost 3/4 lower infection rate for lower perioperative blood sugar targets. What about A1C? There are a number of articles in the literature saying if your patient has a high glycated hemoglobin, glycated A1C, then there's a higher risk of infection. This article by King showed that if you do a multivariable analysis looking at the usual risk factors and looking at post-operative blood sugar levels, if you control for post-operative blood sugar, high A1C or glucose before the operation is not significant. Now, what is true is that if your patient is diabetic and has a higher A1C level, that means the blood sugar has not been well controlled before the operation, and controlling it at the time of the operation will take more work. But if you do control it, then the A1C is not important. So postponing an operation due to a high A1C doesn't benefit the patient as much as making sure if you see a high A1C, you should be taking frequent blood sugar measurements during and after the operation. and using insulin to control blood sugars. This is another study that looked basically at the same idea. And what it showed was that controlling the average blood glucose during hospitalization reduced infection risk, but A1C was not significant once you controlled for the average blood sugar during the hospitalization. So A1C is not associated with increased mortality or perioperative glucose or infections, but it does mean you need to work harder to control blood sugar levels. So glucose control, there are studies showing very clearly that it makes a difference in cardiac, general, colorectal, vascular, all these different things. So if you don't see your specialty on this list, does that mean blood sugar doesn't matter? No, of course not. Clearly it matters for all types of operation. Regardless of whether the patient is diabetic or not, high blood sugars increase morbidity, mortality, and length of stay. The exact best level of glucose control is not known, but we do know that a lower level like 110 to 150 is better than high levels like 180. High blood sugars increase risk of infection and other infections. Tight glucose control is tricky, and in order to do it well, you should have a collaborative agreement and protocol that has been agreed to by surgeons, anesthesiologists, nursing, pharmacy, and endocrine. Hypoglycemia increases the risk of morbidity and mortality. You don't want to use something that gets your patients having blood sugars under 70, which does increase risk. Here are some things that are less frequently talked about. What about teamwork, communication, discipline? This is an interesting observational study where they looked at the behavioral marker risk index. That is, they examined what goes on in the operating room. They looked to see if there was briefing, if the operative team shared information, if they were able to ask questions, if there was vigilance and awareness. Patients with low, in operations where there was a low behavioral marker risk index, there was almost a 5-fold increased risk of complications. This was a stronger prediction than the American Society of Anesthesiology risk index for bad outcomes from operations. This is a study that I had the privilege to participate in many years ago when the World Health Organization developed the idea of the surgical safety checklist to be done before and during operations to make sure that everything necessary for the patient's safety was being done. It's a before and after study done in 8 hospitals around the world. What we see is that infection rate was cut in half by the use of the checklist. Also, unplanned return to the operating room, any complication, and mortality were reduced. This study was done in 4 high-level countries like England, Canada, and New Zealand, and in some low-income countries. And some of the critics of this study said, oh, it was the low-income studies that showed the difference. Actually, it didn't. It was true in all countries. But the next study of a checklist was done in the Netherlands, which we know is not a low-income country. And they had the same outcome of decreases in infection, complications, and death with the use of the checklist. And they also showed that hospitals that did a more complete checklist had a lower complication rate than hospitals that didn't complete the checklist. So the checklist and communication make a difference. And this is another study, again, in the Netherlands showing reduced mortality and other operations complications in patients with the use of a checklist. Now, there's a concept that I like to use about potentially preventable surgical site infections. An infection is potentially preventable if all the known preventive measures like prophylaxis, sterile instruments, keeping the patient warm, using oxygen, controlling blood sugar, and so on was available, but they were not used in that patient's care. So if you see an infection and you see that something was left out of the proper preventive efforts, then that's a potentially preventable infection. But if you have done everything you know how to prevent infection, clean instruments, clean surgeons, prophylaxis, and so on, then you have an apparently unavoidable infection. So one thing to do is to look at each infection that occurs and classify it as potentially preventable or apparently unavoidable. So this is not epidemiology. It's like the investigation that happens after an airplane crashes and everything is done to examine what could have been done differently. How many days without an accident? How many cases between preventable surgical site infections? I actually do know a way to have no surgical site infections. Just don't do any surgery and you won't have any surgical site infections. Otherwise, you can't do this, but you should be able to achieve no potentially preventable infections that occurred when you did not do everything that is possible to prevent them. What about staff? We know that somewhere between 20 and 30% of all people walking around in the world have staph in their nose. Those are Staph aureus carriers. There's quite good evidence, as shown in this Cochrane systematic review, that if you treat patients who are known to have staph in their nose before an operation to remove staph in the nose, you can reduce infection risk. These 7 or 8 studies listed here showed a 45% reduction in staph infections with the use of preoperative nasal decolonization for patients known to have staph in their nose. And certainly, you know, we're talking about neurosurgical cases. Those are basically clean operations, and clean operations are the ones where Staph aureus are some of the most important pathogens. This study by Bodie in the Netherlands looked at 5 hospitals. They screened over 6,000 patients and found that 19% were positive for Staph aureus, and they randomized them to have decolonization or not. And what you see is that there was a reduction in any surgical site infections throughout this case. And what they found is that you only need to treat 23 patients to prevent a Staph aureus infection if the patient contains Staph aureus. And by the way, they had no MRSA. In the US, there's a lot of thought about just screening patients for methicillin resistant. And that's important to know because you need to choose an antibiotic in addition to a cephalosporin if there are MRSA. But MSSA is still a bad infection, and you can prevent them if you screen for staph and decolonize. Now, mupirocin is the most commonly used agent for preventing staph colonization in the nose, and it's generally effective. But the standard protocol is to use it for 5 days before operation, and many patients who don't do this at home. Phillips in New York compared patients getting mupirocin or just getting povidone iodine in the nose 2 to 3 hours before the operation, done 3 times by the nursing staff in the operating room. And what he found was there was actually a lower rate of infection using povidone iodine, probably because it was more effective given immediately there compared to patients not using mupirocin as directed for 5 days before the operation. In terms of long-term use, however, mupirocin keeps the staph out of the nose for a longer period of time after the operation than the povidone iodine. Those patients become recolonized in a few days. And I've already talked about this. I think you need to treat any kind of staph, whether it's sensitive or resistant. Now, when should this be done? This is an interesting study from England. An orthopedic group said that they wanted to treat, they screened all their patients to see if they had methicillin-resistant staph. And if they did, they decolonized them. And they had to prove that the patients were decolonized, but then they could wait up until 3 months before doing the operation. And when they did the operation, they gave cefuroxime. And what they found was that there was a high rate of methicillin-resistant infections because they had waited 3 months and the patients had recolonized. And they used an antibiotic not effective against resistant staph. So if you're going to decolonize your patients for staph, it needs to be done immediately before the operation, not 3 months ahead of time. Now, one of the things that some places do is just use vancomycin if they're worried about methicillin resistance. But in this interesting study done in Australia, Bull looked at over 22,000 patients having cardiac surgery or joint operations who were treated with either a cephalosporin or vancomycin. And what they found is that patients treated only with vancomycin had a higher rate of infection with methicillin-sensitive staph. So if your patient has resistant staph, you must give vancomycin. But vancomycin is not as effective as cephalosporins for methicillin-sensitive staph. That is why in our guideline for antibiotic prophylaxis, we recommend that if a patient is at risk for methicillin-resistant staph, give vancomycin, but combine it with cefazolin. Give both drugs for patients where you are worried about methicillin-resistant staph. What about surgical technique? Well, we all know that the definition of ideal surgical technique is how I would do it, right? Of course. Or the way my chief made me do it when I was in training. But what we really want is minimal tissue trauma, minimal blood loss, minimal foreign bodies, and a short operating time, which must be achieved without sacrificing trauma, blood loss, or foreign bodies. This is an interesting study looking at laparoscopic gastric bypass, which were recorded on video. And then the videos were sent to a large group of surgeons, and the surgeons were asked to say, just look at the video and say, how skillfully was the operation done? And what they found is higher skill is to the right here on the horizontal axis, risk-adjusted complication rate here on the vertical axis, and patient and operations that were judged as having a high rate of skill had a lower rate of complications. I haven't seen that study done in neurosurgery, but I think we all can agree that a well-done operation has a lower risk. So, preventing infection, good teamwork, communication at all times. Pre-warm the patient, warm the patient in the operating room. Give enough of the right antibiotic close to the incision time. Repeat for long operations. Stop when the operation is done. Don't shave. Oh, there's a fun study that I've seen, I didn't quote here. You're looking at craniotomies, of shaving craniotomies versus simply shampooing the hair with betadine, iodine, parting the hair and cutting on the part. And in fact, there was a lower rate of infection without shaving and with using betadine on the hair. And the patients loved it because they had hair when the operation was over. Use a thorough skin prep, including alcohol. Keep the patient warm in the operating room. Use a high level of oxygen. Measure and control glucose. Use good teamwork and debrief. Happy to take questions.
Okay. Sir, thank you for this presentation, useful presentations for all surgeons, not for only neurosurgeons. So let me read the questions. The first is from Professor Hasan Kamil Sucu. The cranioplasty study is interesting. Surgical wound infections develop from the patient himself, not from the operating room environment or operation team. Is it correct?
I think most surgical site infections for any operation come from things that happen in the operating room. Now, can a wound get infected after leaving the operating room? Yes. There are a small number of studies in this area. In animals, you can show that a bacteremia occurring shortly after operation can cause a surgical site infection. And so, and there's one study looking in cardiac surgery where the same cardiac surgical team took care of their patients in two different hospitals, one with a good intensive care unit and one with an intensive care unit where infection control was not good. And they had a higher rate of wound infections where the ICU did not do good infection control. And they think it probably came from things like catheter-related bloodstream infections, urinary tract infections, and bacteremias from pneumonia. So it's possible to get an infection after the incision has been closed, but 90+% of all surgical infections occur from what happens in the operating room.
Okay, thank you, sir. The other question, how long after the start of the surgery redose antibiotic should be administered? Does blood loss affect this period?
We do not have good level 1 evidence on this. Our recommendation in the antibiotic prophylaxis guideline is to give the antibiotic at 2 half-lives after the first dose if the operation is still continuing. We don't have level 1 data on this, but we have many, many observational studies, including, I showed one systematic review of multiple studies indicating that giving another dose during the operation definitely reduces infection risk. I know of only one prospective randomized controlled study, which was done in GI surgery many, many years ago, which did show a significant difference. But observational studies show very strong data. And the standard recommendation is after 2 half-lives of the drug. Another recommendation is if more than, I think it's more than a liter of blood loss, give another dose of antibiotic. This again is based on theory, not on level 1 data, but it's reasonable.
Thank you, sir. Dr. Edwin Vasfi from Bulgaria. I would like to ask you, sir, do you regularly operate all the infected patients with debridement, or you prefer to give a try first with taking swab and trying conservatively according to the antibiogram?
I'm sorry, I didn't catch. Do I operate on what kind of patients?
Do you regularly operate all infected patients with debridement, or you prefer to give a try first with taking swab and trying conservatively according to the antibiogram?
Oh, you mean, do we operate and debride a wound infection? Is that?
Yeah.
Yes.
Well, my practice is if the wound is infected, open it. And if you see necrotic tissue debride, but usually if it's a superficial incisional infection, just opening the incision is enough. And if the patient has systemic signs of infection, fever, leukocytosis, then I would give antibiotics. If the infection is only local and the patient is not febrile or with systemic signs, then just opening the wound, sometimes you don't even need antibiotics. If it's a deep surgical site infection, most of those require some debridement and antibiotics.
Thank you, sir. Another question from Edwin. If there is infection and the patient is instrumented, what is your advice? Should we remove the pedicle screws, or we should do only debridement and leave the instrumentation?
Oh boy.
It's a neurosurgical question.
It's a very important question. I can't give any really well-informed answer to that. I do know that at least in joint replacement and in other settings where screws or plates are used, sometimes the hardware can be saved. Many times it has to go. That's a very complicated area where I'm not an expert.
Thank you, sir. Dr. Nurullah Kösmene from our clinic. Thank you, Professor. It was a great lecture. Is there any study about infection rate, about revision surgery? Do you use any medicine in the surgical site?
You mean a revision surgery that is being done, but not for infection?
Not for infection. Yeah.
Yeah.
Yes.
I would for a revision surgery, if there is not an infection at the time of operation, then I would use prophylaxis in the same way I would use it for the original operation. And if the patient, there are also some studies which I didn't have time to talk about today. Patients who have a history of soft tissue infections, even if it's not a surgical infection, have a higher rate of surgical site infections when you do operations. And if you know what germs were causes of the previous history of soft tissue infections in the past, it could be logical to tailor your prophylaxis against those organisms. Also, a patient who has ever had an abdominal infection, which is now completely cured, but needs another abdominal operation. That patient has a higher risk of an infection at this time. And again, using an antibiotic effective against whatever was in the infection the first time is a logical approach, although we don't have good data on that. So if you are doing a neurosurgical operation on a patient who ever had a neurosurgical infection in the past, I think if you were operating on me, I would ask you to find out what the first infection was caused by and use antibiotics effective against that for the next one.
Thank you, sir. The third question from Edwin. Does changing the dressing in a patient with surgical site infection twice or triple helps for fastening the process of healing, or only one time changing the dressing is enough?
I don't know of any good data on this. For abdominal operations, which is what I was doing, you know, once the wound is open, we would change the dressing once a day. But that was just our standard practice. I don't know if it makes any difference in wound healing.
Okay, thank you. From Professor Hasan Kamil Sucu.
Sorry, Güngör, did you read Abdullah Bashir's question or you miss it?
Oh, pardon. Dr. Abdullah Bashir, why shaving the hairs does not reduce the risk of wound infection?
Well, the data on shaving hairs comes mostly from operations, not neurosurgical operations, and comes from many decades ago. When I was in my training in the 1970s, in those days, patients were admitted to the hospital the day before the operation, and someone came by and shaved the area that would be operated that night. And then the next morning, the patient would go to the operating room. And research showed that that shaving caused very small skin injuries, which then got bacteria in them, and that increased the risk of infection. So the standard now says if you need to remove hair, do it right before the operation and use clippers and not a razor. Although maybe if you did it immediately before the operation, it wouldn't matter. That has not been studied. So that's the theory as to why removing hair, as was done decades ago with a razor, hours before the operation. That's why it is thought that caused more infections. As I say, I'm only aware of one neurosurgical article, and it's somewhere on my hard drive, but I didn't put it in my slides. But in that paper, they were doing craniotomies, as I said, and the group without hair removal, they did a vigorous povidone iodine measure of the scalp and the hair, and then they just parted the hair and cut along the part and had a low infection rate.
Thank you, sir. Professor Hasan Kamil Sucu, in the publications examining the relationship between glucose level and surgical wound infection, I noticed that the infection rates increase slowly at values up to 220 and 250 milligrams, but the infection rate suddenly peaked after these values. Is there a reason for this?
I'm sorry, peaked after what?
220 and 250.
Well, many different articles peak at different levels. What what clearly I think is most important is every article shows what I called a dose response curve. Any level, you keep going above that, you get higher infection rates. Where to make your goal that you will shoot for is still an area of controversy, but we do have that one meta-analysis that I showed that we did for the World Health Organization, showing that some target below 150 achieved significantly lower infection rates than a target below 200.
Thank you, sir. From Edwin Basfi, if the patient is on long oral corticosteroid therapy due to autoimmune disease, should we stop the corticosteroids before the surgery in order to reduce the risk of infection? What do you think?
I am not aware of any good data on that particular topic. So I can't say I know the answer.
Okay, thank you, sir. Let me ask the last question. This is my question. What do you think about the medico-legal extent of surgical site infection?
Sorry, the what extent?
Medico-legal extent of surgical site infection.
Medical legal. Well,
Yes.
you know, medical legal is another very touchy topic. And I don't know of any level 1 data about it. My understanding of the risk that a surgeon may get sued by a patient has to do with how severe any complication was, but also how well the surgeon and the patient talked and shared information, and how well the patient feels well informed and well treated by the surgical team. In terms of a legal sense, we get back to potentially preventable infections. If the patient's lawyer can show that there is a well-documented way to reduce infection risk, and that was not used and the patient got an infection, then I think the surgeon is at higher risk. But good communication between the surgeon and the patient's family is as important as anything else in preventing medical legal problems.
Okay. Thank you, sir. From Abdullah Bashir, thank you very much, dear professor, for informative, valuable informations. And a thank from Edwin Basfi, thank you very much for your excellent lecture. I think there is no other questions or addition. I give the floor to Professor Hasan Kamil Sucu.
Okay. I want to thank again to Professor Dellinger for your excellent lecture, and I want to thank you for accepting our offer to speak in our online conference. Thank you so much.
It was my pleasure.
Thank you. And I want to thank everyone who joined us tonight. Thank you. Bye-bye.
Okay.